Penile cancer. Background. Anatomy. The glands is the most common location. Pathology. 95% squamous cell. Bones and erythroplasia are carcinoma in situ conditions. Workup. H&P. Assess sexual risk factors and do an inguinal node exam. Biopsy. Do a punch biopsy. Do an excisional biopsy and incisional biopsy. Biopsy. Suspicious inguinal nodes. Dynamic sentinel lymph node biopsy. For low risk TIS, TA, and T1A disease. Dynamic sentinel lymph node biopsy or inguinal dissection for T1B disease or greater. MRI pelvis for any invasive disease. Staging, 5-year overall survival, AJCC 8th edition staging, T-stage, T1, invasion of layers superficial to the corporal tissue, T1A equals no LVSI, PNI, grade 3, and not poorly differentiated, T1B is LVSI or PNI or grade 3 or sarcomatoid, T2 is corpus spongiosum invasion with or without urethral invasion, T3 is invades corpus cavernosum with or without urethral invasion, T4 is invades adjacent structures like the scrotum, prostate, or pubic bone. M1 is distant metastasis. In terms of nodal staging, clinical nodal staging, N1, single mobile unilateral inguinal lymph node. N2 is multiple mobile inguinal or bilateral inguinal nodes. N3 is a fixed inguinal or any pelvic node. N3 is by definition stage 4. Pathologic nodes, N1, 1 or 2 inguinal nodes with no extranodal extension. N2 is 3 or more inguinal unilateral nodes or bilateral inguinal nodes, and N3 is extranodal extension or pelvic nodes. Management for in situ or non-invasive disease is typically topical therapies, laser or wide local excision. TIS, TA, or T1A, you can do limited excision with the goal to preserve penile length and sexual function. TIS, topical therapy with 5-FU and imiquimod cream for 4 to 6 weeks. TIS with laser ablation, carbon dioxide, argon, and potassium titanyl phosphate laser ablation has a high rate of preserving sexual activity and satisfaction. TIS, you can do total glands resurfacing, which is removal of the epithelial and subepithelial layers of the glands down in the corpus spongiosum, followed by skin graft. TIS or T1 can also have Mohs surgery, layer by layer excision to maximize organ preservation, and then after that, brachytherapy or external beam radiation therapy is also an option. In terms of management of primary, again, circumcision if not already done, as we said, T1 lesions can get a wide local excision with 5 mm to 1 cm margins or a partial penectomy or radiation, which is category 2B. For T2 lesions or greater, a partial or total penectomy or radiation. You can add chemo to radiation of T3 or T4. If you have a tumor that's less than 4 cm and node negative, you can treat with brachytherapy alone or external beam alone. Interstitial implant, needles about 1 cm apart, equidistant, iridium 192 to a total dose of 65 gray over 4 to 5 days. Lesion with a 2 cm margin to 66 gray at 1.8 gray per fraction with bolus would be your external beam treatment. If you have greater than 4 centimeters, then circumcision followed by chemo rads. Brachy complications occur when the tumor is greater than 4 centimeters. This would be 45 gray at 1.8 gray per fraction to the whole or partial shaft, followed by a boost to the primary lesion plus 2 centimeters to a total of 66 gray and 1.8 gray per fraction, all with bolus. T3 or T4 lesions can be treated with penectomy or radiation, the same dose and volumes as greater than 4 centimeter lesions above. We treat 45 gray at 1.8 gray per fraction to the whole or partial shaft with boost to primary dose, to the primary lesion plus 2 centimeters to 66 gray. If you have positive margins, you treat to 50-40 at 1.8 gray per fraction to the primary site. You only add chemo to the treatment if the patient is node positive. Management of nodes, if clinically node negative, you can start with sentinel node biopsy. If clinically node positive, then you do a bilateral inguinal nodal dissection. If more than one inguinal node is positive, then you dissect the pelvic nodes. If the pelvic nodes are positive, especially if there are multiple pelvic nodes or ENE, then you add chemo RT to low pelvis and inguinals. You do 50-40 at 1.8 gray per fraction with a boost to 66 gray for gross intact nodes or extranodal extension. Technique for simulation: CT supine, place Foley, suspend the penis with tissue bolus to create a shell that holds the penis and also acts as a bolus. Frog leg if treating inguinals. For brachytherapy, you want to use a radioactive mold. Interstitial 192. 60 gray LDR over 4 to 5 days. Your script is to say, I would place the patient under anesthesia with pre-op antibiotics. I would sterilize the drape and place a Foley catheter. I would insert interstitial needles such that the CTV is covered in a parallel fashion, avoiding penetration of the urethra and dorsal vein. After placement, I would examine the urethra for blood and mobility. 60 to 65 gray irradium 192 interstitial implant and limit the urethral dose to 60 gray versus external beam radiation 40 gray to the shaft in the box, followed by a 20 gray boost with 2 centimeter margins with cisplatin. Circumcision prior to radiation decreases side effects. Toxicity follow-up: 3600 centigrade dose, target V125 less than 40%, V150 less than 20%, urethra V115 less than 10%, V90 less than 95%. Outcomes: penile preservation with definitive brachy is 70 to 80%, with external beam is 50 to 60%. Toxicity: penile necrosis in 3 to 15%, higher with interstitial brachy in doses of greater than 60 gray.